Hello, my name's Ian McCall. We're going to have a little look today at the condition Necrobiosis lipoidica. It's not a common disorder. It classically occurs in the front of the shins like this. It's usually a red, non-scaly disease. And it's often seen in diabetics or in people who are pre-diabetic, but it's the location of the rash. It often looks slightly orangey like this, often a slight yellowish tinge, in fact, in the center. We'll just go to a bigger image of this one just now, just to let you have a close look at it. What you could understand in this patient is she previously had a lesion here. You can see the outline of it here. And now she's got little recurrences occurring. You can see that sort of orangey yellow color to it. There isn't much in the way of scale here because the process isn't in the epidermis, it's all in the dermis. I've said that this condition is commonly seen in diabetics. Well, point of fact, only about, I think, 22% of people with necrobiosis lipoidica will have diabetes, but that's still quite a high number. But on those patients who have diabetes and have necrobiosis lipoidica, they're much more likely to have retinopathy, neuropathy. The complications of diabetes seem to be more marked. In this condition, there's damage to the collagen under the skin in the dermis. And it's the reaction to that that causes this rash to come up. The rash usually doesn't cause any itch or any irritation at all. We'll slip back basically to the text here. The condition, as I say, is seen in diabetics and pre-diabetics, non-scaly, not itchy, it just slowly expands. We usually treat this with a little bit of intralesional steroid. We take some Kenacort and dilute 1 ml of 10 milligram per ml Kenacort with 3 ml of local anesthetic, and we inject it into the expanding edge of these lesions. And that usually causes them to involute, if not with the first injection, certainly with the second one. Now, you may well be saying, what, you're giving steroids to someone who's a diabetic? It's a relatively small amount of cortisone you're going to use. It's not going to cause them any issues, in fact, at all. We should have a little look at some other examples of this because I think it'll show it more clearly. One other little point I've made here is about doing a punch biopsy. If you are going to do a punch biopsy here, do it of the edge, the expanding edge of a lesion, and put a suture in it because they are often very slow to heal. Let's look at some other images of this. This was just an enlarged image of the case we were seeing there. Some other pictures. Here's another case. You can see the edge. Edge looks a little bit more scaly in this particular one, but there's usually no scale in the central area here. You sometimes can see the veins through the pathology because there's a bit of thinning of the overlying epidermis. If you're going to do your injections, you'll inject it into that edge there. This one's more scaly than usual. There's a lesion. You can see the yellowish color of the fat underneath. You can see there's a degree of atrophy here, and that's not because it's been injected with steroids. And you can see the prominence of the superficial capillaries. Yeah, it's probably a better example of the more typical lesion of necrobiosis lipoidica. Slightly raised edge. You can see it here. Not much in the way of scale at all. The yellowish fat underneath here, the thin little branching capillary vessels in the surface of the skin. Here's another older example. Again, the yellow tinge in the center, the veins being prominent through here. Again, the location, classic location, front of the shins. Yep. Central epidermal thinning. papular non-scaly edge usually. Here's another example, more prominent edge to this one. Slight suggestion of some scale at the edge there. Anytime you have anything that's, looks ring or like that with a scale, you always take some scrapings of the scale anyway, just in case you've got some form of modified tinea infection. Here's another example. Red, not much in the way of scale, front of the shins, typical location. Here's another example where, in point of fact, it's ulcerated. You've got to watch these lesions. If they're injured, say you were out working in the garden and something penetrated that, it takes a long time for it to heal. And that's simply because of the pathology here. It would appear that, with diabetes especially, you've got a poor peripheral circulation, you've got impaired degree of vasculopathy, and any type of ulceration, any type of traumatic injury takes a while to heal. That's why I was saying if you're doing a biopsy, take it from the edge and suture it to give it any chance to heal. The treatment for Necrobiosis lipoidica, as I say, it's the only really effective one is a bit of diluted kenacort into the advancing edge there, and that will often stop it in its tracks. It's very useful for early lesions to get in and treat those. Other therapies that have been used have been vasodilators, including drugs like Trental, Trental, pentoxifylline, that just increases local skin blood flow. The level of the blood sugar and the degree of diabetic control doesn't really seem to be related to the severity of this, which is a bit surprising. And the condition itself can sometimes precede diabetes by 2 to 3 months. So you wonder just exactly what the underlying pathology is in those circumstances. As I say, an unusual condition. The idea is to see it early, treat it early with the diluted intralesional kenacort, and certainly avoid trauma to the area, avoid ulceration occurring. As a basic principle, we try and keep the person's diabetes under as good control as possible. Consider a drug like Trental. Various other things have been tried in this condition, but there's no good evidence that any of them are any better than placebo, in fact. So, Necrobiosis lipoidica, just think of it whenever you see a rash on the front of the shins, and especially in someone who may have the metabolic syndrome, who may be pre-diabetic, or in fact, who actually has diabetes. Thanks very much.